Welcome to IRG's Health Talk. I'm Tom Hutler along with Shannon O'Kelly, physical therapist and president of IRG Physical and Hand Therapy. And our guest, Dr. James Crutcher, orthopedic surgeon from OPA Ortho.
Dr. Crutcher, welcome. Thanks for joining us. As an orthopedic surgeon, you have a very specific interest in your practice. Tell us about your interest and tell us about your practice.
Well, my practice is a specialty of joint replacement surgery of the hip and knee. So I'm an orthopedic surgeon. I trained here at the University of Washington, and then I did a fellowship for 1 year specializing in hip and knee replacement surgery. And since that time, about 25 years ago, I've been practicing here at Swedish continuously and focusing on arthritic conditions of the hip and knee. And what I do is treat people both non-operatively and with surgery who have advanced hip or knee arthritis. Most of the time, that condition progresses to a point where they need joint replacement surgery, which is a very successful operation most of the time.
And tell us, you just mentioned you have 25 years of experience, so you've probably seen a lot of changes in total joint replacement, and particularly in the knee. In today's world, we talk about total knees versus partial knees. We're going to talk about that a little bit, but tell us who becomes a candidate for those replacements?
Well, knee arthritis is a progressive condition. It starts out with some pain that can be treated non-operatively, either with some over-the-counter medications, Tylenol, etc., sometimes requiring prescription medications, and sometimes as that disease process advances, injections may be appropriate, bracing. But ultimately, this condition will progress to a point where the knee is totally worn out and joint replacement surgery is appropriate. The timing of that surgery really depends on the extent of disease and how symptomatic the patient is.
So really, when people come to you and you make a decision to do a joint replacement, particularly in the knee, it really boils down to quality of life. I mean, the patient's just not experiencing any kind of activity without pain anymore.
That's correct. This is all about quality of life. And it's more about quality of life and mobility and function than it is about age or extent of disease. Some people have a very slowly progressive process that goes on for many years before they need the surgery, and other people, the condition deteriorates quite rapidly and they need knee replacement within a year of their first symptoms.
As we prepare to talk about your replacement options, let's be, if we can, I know we're on the radio and anatomy sometimes is hard to explain, but I think it's important that our listeners understand the knee joint and the way it's configured, and particularly when you and I talk about the condyles of the joint and how that knee joint looks and functions and how that relates to replacement options.
So the knee is a fairly complicated joint. Of course, it's the joint between the femur or the thigh bone and the tibia or the shin bone. And there's multiple components of that. There are two types of cartilage. There's a meniscus, and then there's a surface cartilage, which we call articular cartilage. And many of you have heard of getting a torn cartilage in your knee that's often treated arthroscopically. That's the little meniscus or the gasket in your knee. It's really the surface cartilage over the end of the bone that is the main structural component that's involved in arthritis. And when that surface cartilage is kind of like tread on a tire, over time it can wear down to a point where there is no cartilage and you have bone on bone. And that's a condition that's usually refractory to any type of non-operative management. And that's the type of patient who would be best served with a joint replacement.
And so a patient presents to your office. I mean, you take a history physical, you're going to maybe do some diagnostic tests. And as a surgeon, it's really your job to kind of decide what is the best replacement procedure and what is the best outcomes for this patient. How do you determine that?
Well, first of all, I like to get a history. As you said, I like to ask the patient what are their symptoms, over what period of time have they been progressing, and how are they manifested? What types of activities cause them pain? Where is the location of the pain, because that determines whether or not they may be a partial or a total knee replacement candidate. I like to ask patients what they do, what they want to be doing, what they haven't been able to do. So if they're used to walking for exercise and now they can't, if they're used to, if they were a runner for many years and now they can't, if they have trouble hiking, carrying loads, these are some of the things I like to know, because I want to know what is the level of function they would like to have and what have they lost. And I also need to have a discussion with them about what's realistic to expect. Most of the time, when patients have advanced knee arthritis to a point where they need joint replacement surgery, it's unrealistic to expect they'll get back to running. The one activity we really don't encourage is high-impact activities like running, jogging, playing full-court basketball. Anything else will probably work just fine. So medium to low impact activities such as walking, hiking, swimming, biking, even skiing, doubles tennis and golf are all well tolerated with a knee replacement.
Yeah, a lot of great options for those patients in today's world of medicine, particularly since now they can do this partial versus total. And tell us the difference between those two procedures.
So the partial knee replacement is indicated for a patient who has advanced arthritis in just one part of the knee. So the knee typically has three compartments. There's the medial or inside compartment, there's the lateral or outside compartment, and then there's the patellofemoral compartment, which is underneath the kneecap. And generally, people who have arthritis, all three or part of all three of those compartments are affected. And 85% of the patients that we see have that pattern and will need a total knee replacement eventually. If you happen to have a pattern of arthritis that just affects one of those three compartments, then you may be a good candidate for a partial knee replacement. And that's how we decide the difference between a partial and a total knee replacement.
Yeah, I'm always fascinated with orthopedics because essentially you're trying to look at this joint and duplicate. I mean, it's configured very interestingly. And as a surgeon, how do you determine the size of replacement and components? And there's a lot of thought that goes into this because ultimately you're looking at this patient succeeding 10, 15, 20 years down the road.
Well, we have multiple options in terms of sizes of implants. So every implant system has 7, 8, 10 different sizes of implants, all of which are a few millimeters difference in size. So we have a size that fits everybody. We choose the design of the implant and sometimes the materials based on the patient's individual characteristics.
In today's world, sometimes often on the television, I know I've seen several times that there's robotic surgery available for patients with total joint replacements. Are you doing robotics, or is that something that you're looking in the future to do?
We are, Shannon. This is a pretty exciting area. Robotic-assisted surgery has been available for 5 to 6 years. We have been using robotic-assisted surgery at Swedish for about 5 years now, only in the partial knee replacements. It's not yet available for a total knee replacement, but it is going to be available in the next year or two, and that's a pretty exciting thing to look forward to. The robotic surgery is not a robot, the way you would think of a robot. It's really much more than that. It's a very, very precise computer-assisted surgery. And what we do with the robotically assisted partial knee replacement is we look at a patient who's identified as a good candidate for a partial knee replacement. We take a CT or a CAT scan of their knee and get a very high-resolution image of that particular patient's knee, and we use that to map out on a computer with a very sophisticated algorithm exactly where the implant should be, and we can plan with a virtual surgery ahead of time the exact position, alignment, and size of the implants. And this particular technology, which is called Mako, allows us to do some intraoperative fine-tuning of the implant position so that the balance of the knee comes out optimally. Particularly in a partial knee replacement, this is true for a total knee replacement as well. The key to success is having a very well-balanced knee with respect to all of the different ligaments. It's analogous to taking a 5-legged stool, sawing off one leg, and then rebuilding it so that all 5 legs hit the floor at the same time and be perfectly balanced. And it's very hard to do with older conventional instruments to do it perfectly every time. And this computer-assisted robotic surgery allows us to do this very, very precisely, and we're adjusting the position of the implants by a millimeter or two and by a degree or two, and it's very, very accurate. The robotic part of it has to do with bone preparation. So we feed this information into a computer, and that guides the surgeon's tool, which is a haptic robot. This is like a burr that has constraints. So the surgeon uses this. It's not like a robot you would think of, you turn on a machine that's just operating on someone without any controls. The surgeon is actually doing the operation with a tool that's guided by the computer. It's called a haptic robot, and that means that the burr is not allowed to stray outside certain constraints, and that way we can prepare the bone in a very accurate fashion.
So basically, you can't color outside the lines. I mean,
exactly. That's a perfect analogy.
Yeah, you can't color outside the lines, and ultimately what you have with a partial knee, because the components are smaller, you have better placement accuracy-wise, and outcomes are much better for the patient, I would imagine.
Outcomes are great because we can be so precise with the implant position and the ligament balance. Now that technology is not yet available for a total knee replacement, but I think it's going to be available in the next year or two. And to me, it's very exciting because the total knee replacement really has the same principles. We're talking about restoring the joint surface inside of the constraints of 3 or 4 ligaments that are all interacting with each other in a complex way. Another analogy is to think of a tent. If you put up a tent and you don't get all the internal poles just right, then the tent isn't set up right, and you don't have the dome isn't supported well. So we're trying to take 4 or 5 different struts inside of a knee and get them all perfectly balanced in a very complex motion. And the CT-guided or computer-guided navigation and robotic preparation really help us do this very, very well.
Okay, so one of the things I've experienced and I've heard a lot in my practice over the years from folks, patients that have had their knees replaced, either total or partial, it's just how pleased they are. I mean, they commonly say, I should have done this a long time ago. So for those patients and those listeners out there, when it gets to the point where, you know, your quality of life is interfered with because of pain, there's options for it. And you don't have to be 65 or 70 anymore. You can do this at an early age now.
Yes, the materials we have now are much, much better. We expect most knee replacements under normal activity levels to last 30 years. So that's a huge improvement over what we had even 10 years ago. And it really is not age dependent. This is a quality of life issue. So if you are 70 years old or if you're 49 years old, if you have end-stage arthritis that's not allowing you to do normal activities and you have to be dependent on walking aids and or medications to just get through your normal day, then a joint replacement surgery may be a very good option for you.
Okay, how would our listeners get a hold of you if they had more questions?
They can call our office at OPA, which is 206-386-2600, and ask for an appointment with myself or any of the joint replacement surgeons there.
Thank you.
If you'd like more information on this topic, as well as how to contact Dr. James Crutcher, go to opaortho.com, irgpt.com, and click on the Health Experts tab, or go to IRG Physical